If you see, I try to resolve this problem. Well, thank you to all. I'm honored for your invitation and for sharing with you our experience. So, in breast cancer prevention, I hope also to receive comments and suggestions from you. I'm speaking you from Italy and Emilia-Romagna region. That is the region. I don't know if you see the arrow on the computer. Do you see?
Yes.
And precisely from Ferrara, that is a town in the northeast of the region. Well, in a brief introduction to better understand our situation. We are a region of about four. I have a. I'm not able to speak. I have a return.
But we hear you very clear. We hear you very clear.
I have a double. Huh?
We can hear you well.
Well, I try another time. You see the presentation?
Yes.
I have several problems with this program. I try to continue. Well, I'm speaking from a region of 4,500,000 of inhabitants. 51% are women, and in a system, in a national health system, universal since 1978. In our system, each citizen pays according to his income and uses everything he needs. This is important because screening is so totally free of charge, both the first and subsequent exam. So we potentially have no biases, no selection biases on invited women. So every invited women, we invite all women of the region. This is the situation of breast cancer incidence and mortality in Europe, and it's possible perhaps to say that Italy has a middle risk for incidence, but a low risk of mortalities. And this probably is due to our health system and screening program, although they are not uniformly distributed in the country. The coverage is not uniform among all the regions. These are our main data, epidemiologic data. We have 4,000 and almost 4,500 cases per year of women breast cancer, and a mortality of 29.3 per 100,000. when the mortality is decreasing from several years, and an extremely high survival, one of the highest survival in Europe for breast cancer. These are our data of prevalence. We are about 30,000 breast cancer in women living with breast cancer in our region, and 1/3 of the women cancer incidence is due to breast cancer, so an extremely important pathology. Tell me if something in the communication is wrong, or if you don't watch, if you see the presentation, please. Then screening. Breast screening respect all the fundamental criteria for a screening program. The burden of the disease is high. The preclinical phase diagnosable is long to allow an improvement of prognosis. We have a availability of treatment to improve prognosis and a favorable cost-benefit ratio. These are fundamentals. Without them, it's impossible to manage a screening program. The organizational needs in a screening program is the definition of a target population. It's important to reach an adequate coverage and compliance, real path for people, and quality control program, and all the study that improve quality of the program and its impact on the whole population. The main indexes of efficacy of the screening are mortality reduction and downstaging of lesions. Overdiagnosis and overtreatment are a danger for a screening program because its cost effectiveness become impossible. And survival is an index that should not be used in evaluation of the screening program. Survival increase always when we start with the screening program. But as you can see in this slide, we must use the lead time, the time of early diagnosis, to improve prognosis of patients. In the first line, there is no screening. In the second line, there is an early diagnosis, totally inefficient, totally unuseful, because in this second line, the overall survival time increased due to the lead time, but the prognosis don't change. In the situation on useful screening, the lead time must be used to improve prognosis. So survival increase always during a screening program, especially in the first phase of the screening program. But it is not an index to study to control the screening efficacy. I speak you from Ferrara. Ferrara, my province, has started with the first screening program in Italy, and one of the first in Europe since the 60s, since the 60s of last century. This is a publication, an answer publication of the first result of a screening program that was a bit different from the one we have now. But since the 60s, was clear that it was needed a strategy to improve prognosis in cancer than in those years where diagnosis in later phase. In Italy, as you can see in this picture, now screening is a so-called needed level of assistance. Every region must be guaranteed to its citizen some exams, some practices, some some health program. And the screening is compulsory in Italy. Every region must organize breast, cervical, and colorectal screening for his citizen, with an active invitation of resident women, principally of resident women, with surveillance of covering of the screening, and when promoting a conscious participation of women. Screening works under strict guidelines, and these are the European guidelines we share with all European countries. These guidelines regard in screening age and frequencies, organization of the screening, use of senologies, the diagnostics in senology as tomosynthesis. They are a current problem we are studying on, and some study for targeting the screening, especially now in women with high breast density. So we have several European lines that are adjourned progressively. And these are the recommendation in the European Union for screening. Till 45 years old, women are not recommended to have a screening. This is a conditional recommendation with moderate sensitive evidence, but screening is not admitted for young women because the characteristic of the breast and the incidence in this year not correspond to the criteria that have to guide a screening program. 50, 70 years interval is a classic interval when the evidence are more clear, and with the screening every 2 years, here the recommendation is conditional, and the certainty of evidence is very low, but in practice, this interval is recognized all over the world as the best intervals to start with the screening. And 70, 74 years that have practice, that have in practice the same risk of the preceding class. 45, 49 years is a border level in which there are no sound evidences of efficacy of the screening, but in which there are some reasons, some public health reason to include women in this program. Screening have also several need about radiologist clinical competence, and here are the rules we follow for our radiologists who perform the screening. Screening is performed through two-dimensional mammograms, and all new radiologists must be an appropriate training to perform. This is our program and our path during this year. In the middle of the 90s of last century, we started with screening programs covering all the regional country. In 2010, we introduced the general reorganization of all breast diagnostic services. I will show you some critical points of this strategy. In 2012, we introduced a special protocol for breast and ovary heredofamilial cancer risk. And in 2012, we completed the strategy for diagnostic senology in every age and in every condition of women about breast cancer. In 2018, we started with a new organization of a shared regional breast units network. And now we are reaccredited all the program for reaching the better quality in this. The organization is on the basis of a provincial health unit. The targeted women, in our experience, were 45, 74 years. We included 45, 49 years. Also, if there were not particular evidence of efficacy of the screening in this year, because we found that these women and general practitioner asked for these women many and sometimes inappropriate exams, mammographies, echographies, and so on. So we included this class of women to better introduce them to the screening and to avoid unuseful practice in this age. We follow the coverage of the program in a regional mode with control every 6 months of the coverage of the program, with collaboration with a regional cancer registry that cover the region from several years, and with meetings, annual meetings in which this organization program are discussed, coverage quality, and outcome control and outcome study also are presented. This is our program. First level with the invitation letter, mammography, two-position mammography. The mammography is read by 2 independent radiologists, and the senior radiologist can read in case of discordant. In discordant case, there is a senior radiologist who close the diagnosis. Women with negative exams were sent a home letter and invited to the next round of the screening, and women with positive exam were recalled by a phone contact and invitation to seventh level, in which they have a visit by a senologist and all the exams that the senology consider useful for deepen his diagnosis. So echography for the mammograms, magnetic resonance, according with his needs. Also in this phase, women can be reassessed to the negative exit, and so re-invited after 2 years, or she can proceed to the further diagnostic phase. I asked the microhistology to deepen suspect picture of the RX. This is our network of breast cancer centers from 2018. We moved on the thought that build a system from that can follow women from prevention, so screening, and diagnosis, therapy, and follow-up within a unique path, with a total taking charge of women since the phase of diagnosis and of prevention. We have 12 breast units linked in one regional model, and they are paths and not structures. This permitted us to improve the quality and the efficiency of the whole system for breast cancer prevention and care. The steps are prevention, diagnosis, first-time treatment, adjuvant therapy, metastatic disease and recurrences, follow-up, rehabilitation, and palliative care, as you see. A global program in this path have been written for guaranteed the most accurate and the most appropriate diagnostic test in every need of the women. For asymptomatic women till 40 years, no screening is provided. General practitioner, in some cases, can ask a visit, a senology visit, that is given within 90 days from the request. In 40, 45 years, if a general practitioner or a specialist ask a mammography, the first taking charge with mammography in suspected women is given within 9 days from the request and subsequent within 12 months. In 45, 49 years, we have a screening. We start the screening with a yearly mammogram. Every year, women are invited to mammogram. From 50 to 74 years, there are ordinary screening with the 2-year mammography every 24 months. And over 74 years, there is the possibility to ask a mammography by a general practitioner, especially if needed by some clinical condition. Symptomatic women, instead, are divided in absolute urgency or deferrable urgency. As you can see, absolute urgency is defined on the basis of this picture. Neonatal discovery, skin or nipple retraction, persistent blood discharge, nuclear erosion, or palpable axillary lymphadenopathy. To these women, taking charge is guaranteed within 72 hours from the request. For deferrable urgency, the request is given within 7 days. The mammograms and the taking charge is given within 7 days from the request. And these are the characters that define a deferrable urgencies: local diffuse inflammation, serum blood secretion, and so on. So we have a complete table, a complete schema to assess every woman with every needs, the more appropriate to take in charge from the whole system. These are our professional competencies and requirements according with the international guidelines. Radiology are requested of 1,000 clinical mammography per capita, or 500 screening mammography. A senologist, a radiologist involved in the screening must diagnose at least 5,000 screening mammography per year, and have 30% of dedicated time work to senologic diagnostics. The technician has its own requirements to dedicate technician at least 1,000 mammography per year, and pathologists are requested to have 2 dedicated specialists to this disease, at least with 50 diagnoses of primitive breast carcinoma per capita per year for the referent specialist, and 25% of dedicated time work for the collaborator. So we ensure through the program the best quality we are able to give. All is okay?
Yes, everything.
Well, sorry, I am speaking to myself in this situation. The appropriate analysis. As I told you, in Italy, the coverage of the screening is not it's not uniform. Emilia-Romagna, the region where I speak from to you, has the highest coverage of the screening. Coverage means the percentage, the rate of women who should have a mammography under screening protocol in the time of the screening protocol, the rate of the women covered by the program. So 84% means that 84% of Emilia-Romagna resident women add a mammography under the protocol of the screening or under other type of service within the 2 years or 1 year in 45-49 interval as requested by the screening protocol. As you see, the coverage is not uniform because there are regions that practically are not covered by screening. It's difficult and hard program to follow. The COVID problem has increased the problem. More efficient region, as the one where I speak from, have overcome the problem, and less region did not. In the COVID period, we have stopped the invitation to the first test for 2 months, from the middle of March to the middle of May of 2020. And then we recuperate all the mammography within the middle of the 21. So we now have the coverage of the pre-COVID period. And these are the numbers that our screening program produced. We have 300,000 women followed. This number is higher than the one I showed you before, because we are the only program in Italy that not only invite resident women, but also resident women in the region. There are women that are not officially resident in the region, but they are temporarily present in the region, and we invite them to guarantee all women, independent from their residence, correct taken charge by the program. We have an extension of invitation of about 95, 96, 97%. So practically all population of women that have to be invited are effectively invited, and a coverage program in the whole age classes covered by the program of 71%. So one of the best level that are now in Italy. The screening recalls for the different age classes are those you can see in green. 1 woman out of every 13 examined are recalled to a further examine in the age 45-49, and 1 woman every 23 and 24 over the age of 50. The second level screening identify cancer in a woman out of every 23 in age 45-49, 1 every 8 and every 4 respectively in age 50, 69 and 70, 74. Screening identify cancer in 1 woman out every 300 examined, and other numbers in the different age classes. So we have a good rate of incidence found by the screen, and I will show you. And I will show you what it means about the efficiency of the program. About the quality index, we have recall rate in the different age classes. I asked the women that are recalled to further exam respect to the first level screening. These are the indexes of first round and the subsequent rounds, and they are within the interval requested by the international guidelines, almost all within these index. In detection rate, so the cancers, the carcinoma detected every 1,000 of exams, these are the results, and a good and acceptable positive predictive value of mammogram relating to cancer diagnosis, as you see. Our diagnostic and screening you can see that about 70% of cancers identified by screening are in situ carcinomas or in stage 1 carcinomas, so with a favorable prognosis and with less invasive therapies. Analysis of impact. This is a long discussed problem in this is a long discussed topic between supporters and detractors of the screening, especially at the beginning of 2000, in 2002, several detractors of the screening says that screening increased mastectomies, so it was not appropriate for women. The screening produced an enormous overdiagnosis, so lesions that could not be a real disease, and that the screening does not influence, did not influence the mortality. So we respond with three main studies. Is in a study of several Italian cancer registries and several Italian screening programs of about 5 regions. That's all the northern regions build this study, and this is the first results. I know if you can see the numbers of this picture, but respect to not screened women used as a reference, screening at first test have a 65% probability to have a mastectomy, respect not screened women, and women screened at subsequent test as in practice the 500% of probability to have a complete mastectomy, respect women not screened. So we have verified that the screening allow 50% of women to have a more conservative therapy, and this is not, and that is not true that screening increase mammography. This is a study of 2006 in North Italy, 79 years old, and with a good number of carcinoma followed in this case. That are not old data, because the outcome of the screenings is more clear in the first year after screening starting, and then it becomes less clear in the first year. The first years after screening starting is are the best years in which observe the outcome of the screening. Second study. The second study and the second question was about overdiagnosis of screening. It's clear that in the age of screening, especially in the first period, we have more diagnosis of breast cancer. If not, the screening is not efficient, it's not good. And in fact, we have a 36% of diagnosis than pre-screening period. But if we adjust for the time, so we adjust on the basis of the incidence level before the screening and incidence level after the screening start, we have found a total acceptable level of overdiagnosis, less and less than the one, for example, of other cancers, thyroid cancer or prostate cancer. We had a final overdiagnosis of 4.6% for all the cases from 15 to 74 years, and level of overdiagnosis that's not inferior to 10%. So quite acceptable respect the advantages that screening have for our population. So the level of overdiagnosis is totally acceptable. It's not true that screening increased dramatically overdiagnosis of breast cancer. And the last question, the most important one, screening decrease mortality or not? Because this is the principle, the main index of the efficacy of the screening. In this study, 2006, North Italy, we have studied starting from the screening, the start of the screening to 2001, 50, 74 years old women, and this is a case control study, 1,750 breast cancer deaths versus 7,000 controls. And we have, as you can see, the never responded, the women who never responded to the screening are considered the reference. And screened women have a mortality of 45% respect never screened women. So screening halves the mortality in women, in our experimental condition. Screening unselected for corrected for non-selection. So screened the screening program and the women screening out of the program with the spontaneous mammography and so on has a reduction of 45% of mortality. So these results are dramatic in terms of reduction of mortality. We can, for us, it's very important to have demonstrated that all the program is extremely efficient in decreasing mortality. Our regional population, in the picture on the right, these are incidence and mortality trend, time trend in our population respect to Italian one. As you see, with the typical curve of screening, the start of the screening, the increase of the incidence, and the plateau phase with a low reduction of the incidence that we have seen for all ages. Mortality, the reduction of mortality in our region is higher than the average of Italy. And it is due, as we have demonstrated, to our screening program. This is another study of the same region, of the same 5 region, Italian region, the screening program. We have that taking in account the prevalence and the cure fraction of our women. We have in yellow the trend of prevalence from diagnosis to 24 years, and in green the women that not died, that not will die for breast cancer. This is important to ensure women, to tell women that breast cancer diagnosis is not a death penalty, as often is thought by everybody. We have a cure fraction of 22,076 cases among 30,000 cases total. So a cure prevalence of 72%. 72% of all prevalent women with breast cancer will not die for breast cancers. And this is, for us, a very important result. This is the impact evaluation, same protocol. This is a study regarding only our region, and we see that in the year after the screening start, 1997 and subsequent years, we have a constant trend of stage 1 cases. Low unknown staged cases. So we have all staged cases, and it is evident that stage 2 and 3 has a decrease of incidence. This is the second target of the screening. the decrease of late cases, the decrease of advanced cases. This means that women were protected by against late stage cancer with less invasive therapies and better quality of life and better cost, better effectiveness of the program. This is another study, an Italian study on 400,000 cases, and these are the conclusion. Comparing attenders and non-attenders stage-specific breast cancer incidence, we have estimated that screening attendance is associated with a reduction of nearly 30% of for stages 1 and more than 1. This is very important. This is a great impact on the quality of life and cost effectiveness and less invasive cure of all the women. Another study regarded our regional reorganization of screening with introducing 45, 49, and 74 years. At time we asked us how can what will be the picture of our epidemiology, and these are the results of this strategy. We had a decrease in spontaneous screening in age 45, 49, and 70, 74 because most of women were included in the screening program. Decrease of waiting time for mammography in those ages, demonstrating that most of the requests of mammography in those age are inappropriate and exceeding the needed one. No increase in mammography rates at all age, and favorable trend toward a reduction in waiting time for all age. So our strategy in widening the screening interval also to the age 45, 49, and 70, 74 has been demonstrated to be acceptable because we had good results in this for this strategy. Another important topic is the effect of the screening in 45, 49 years in overtreating, in overdiagnosing and overtreating. What could happen for invasive diagnosis and comparing attenders. Sorry, yeah. This is the right slide. Younger women, obviously, for their most dense breast, experienced 2 to 3-fold higher cumulative recall rates at second screens. But the second screens is limited to diagnostic senology, to radiology, because biopsy rates are not so different with women over 50 years old. So the outcome that we expected and higher recall rates had no significant impact for that regard biopsy. Obviously, this topic is under observation, and the future study will clarify us about this topic. Short-term perspective. Short-term perspective are tailoring, further tailoring of the screening. We have tailored the screening for age because 45, 49 years as a yearly mammography, not mammogram every 24 months as women of 50 years old and over. informing women, because the coverage is always an unresolved problem. Women have to be stimulated to adhere to the screening. We have in program a revision of the update of and an update of Area of Familia program. I will tell you about it soon. An open problem is the use of tomosynthesis in the first test of the screening. European guidelines says that tomosynthesis can be used as a first level, not in combination with two projection mammograms, but only tomosynthesis. And we are reasoning about the opportunity to introduce tomosynthesis in the first level. And this is not a medium, but a long-term perspective, the use of artificial intelligence in the reading the mammograms and in the diagnostic phase of this path. Outcome studies that are in program are those regarding interval cancers. So the cancer arising between a screening test with negative result and the subsequent screening test. We have a rate of interval cancers within the range we expected, but this is a problem that need continuous surveillance and deepen the trends by age and stage of our women to verify the efficacy and efficiency of the screening in all age. Third pillar of our strategy in breast cancer prevention is heredofamilial prevention, because this risk regards few women that are high or extremely high risk due to genetic risk, and these women are not protected by screening because they are younger than screening invitation, and also the strategy of the prevention and following these women are different from the general population. These are the fundamentals of our strategy for heredofamilial cancer. In our knowledge, this is the first population-based program in Europe. We started it in 2012, and they regard the BRCA mutation, germline mutation, on the basis of these K capsids. BR mutation are involved in repairing the DNA during the sex phase, and they are present about in a rate of 5 to 10% of breast cancer, and in a higher rate of ovarian cancers, especially serous and papillary cancer, but also endometrial cancer. Women with germline mutation of BRCA1/2 have a cumulative incidence till 70 years old of 65-45% for breast cancer and 39-11% for ovarian cancer. Triple negative, so cancer negative for estrogen and the progesterone receptor, and the negative for HER2 are more frequent and more aggressive cancer, more frequent in BRCA mutation carriers. And these are younger women respect to the average age of breast cancer incidence. This is our project, our protocol of breast cancer heredofamilial prevention. The protocol is based on 3 fundamental steps. The first, this is the complete algorithm. It is essentially composed of 3 progressive levels. At first, fast screening procedure, a further risk deepening of women that are positive first examination, And finally, a true genetic counseling only to women that need it, in order to maximize the cost effectiveness of the program and to avoid inappropriate genetic test and consultation. This is a crucial problem for sustainability of all the path. All three steps are finalized to identify the three profiles of risk, three progressive level of risk with consequent three different types of taking charge of women. Here the scheme of the process. As a first steps, every woman is invited to compile a simple questionnaire, a simple anamnestic questionnaire based of international guidelines. We don't offer an active invitation at the program because we are not able to guarantee an active invitation as in the screening program, but general practitioners, especially at screening itself, are requested to propose the test to every woman. In particular, screening propose this simple questionnaire test to every woman each time the women come to screening for each round. Until the main role is now played by the screening program, the program has to be improved, especially in younger age. In the region, we have 3 spoke centers that reach women that invite women who are positive to the first level questionnaire. And they manage women with at least a twofold risk respect to the general population. This is the simple questionnaire. The first questionnaire that each woman compile every time she comes to the screening or every time she comes to the specialist. This questionnaire considers several predictors of risk and several scores. If cells, if tagged, attribute the show score. If the final score is 0 or 1, I asked less than 2, the woman is assigned to profile 1, no excess of risk, and invited to adhere to the screening when she will be invited. More than 97% of women stop here their path, and they're reassured about the genetic risk. So this simple questionnaire is extremely important, is a key part of a crucial step of the program for the sustainability of the program that allow us to avoid unuseful and costly actions of 19% of the women. We have linked these women to the data of cancer registry that are active in the region since 1990, and we confirm that these women have not an excess of risk with respect of the general population. So this is the first level. The second step of the screening for women that have a score of 2 or more at this questionnaire is the spoke center. The spoke center assesses the lifetime risk, the probability to have a breast cancer, and the probability of underlying risk of BRCA gene mutation through a test, the thyroid test, based mainly on anamnestic information. At the end of this phase, a woman can be recognized free of risk and returned back to the level 1 of risk, and it's here to the general population, or considered a moderate risk with a relative risk of 2, or at great excess of risk 3 or more, and sent to genetic counseling. This is the test that provide the probability of incidence of breast cancer and the probabilities of BRCA germline mutation. Obviously, the third level test is the genetic unit that deepen genetic counseling and genetic anamnesis of the patient, and in presence of certain conditions, propose the genetic test for test the BRCA mutation presence. Obviously, some women can direct go to it's possible to send these women directly to the genetic hub and not to the preceding point if these conditions are present. For example, breast and ovarian cancer, or cancer within 50 years old. All these, in all these conditions, the women doesn't perform the first level of the program, but she is sent directly to the genetic counseling. Genetic counseling verify the condition to access to genetic test in the presence of all these characters, both breast and ovarian cancer, and so on. There are 11 conditions. I will send you the presentation for a more detailed reading of the single. And these are the possible genetic results. The test could be informative. Is a preceding BRCA mutation are present. Women can be true positive or true negative, and in absence of a preceding parent with a BRCA mutation, could be absence of any mutation or mutation of unclassified variant, for example, TP53. This is the path that is the follow-up path guaranteed to each level of test. This is the first strategy proposed to women at risk. Women with profile 1 are not at risk with respect to the general population, and they are offered the screening protocol from 45 to 74 years as the normal general population. Profile 2 women, medium risk, are more or less the same protocol for profile 1, but they start the screening at 40 years old instead of 45. In brief, they have a slight increase of risk. So the only exam offered is the anticipation of the screening. Profile 3 women at high risk, divided if they have a lifetime risk less or more than 30% or a BRCA mutation, are instead extremely intensive, as you can see, using mammography, echography, magnetic resonance at different intervals, and with this timing every 60 months in some age classes and in some risk conditions. This is an intensive follow-up protocol because these women are at extremely high risk. We have verified through data linkage with cancer registry that women at high risk have a 6-fold risk of have breast cancer and to have it in younger age. So the protocol is extremely intensive. For ovarian cancer prevention, is a bimanual gynecological examination every 6 months is provided with pelvic vaginal ultrasound ecography every 6 months and blood CA 125 dosage every 6 months. This is the follow-up for cancer, for ovarian cancer, and breast and ovarian prevention are both followed for high-risk women. This is instead a protocol of chemo prevention, the second pillar of the project. This protocol is an old protocol because the last protocol of all the program were done in 2016. So we had not still some drugs that are now viable for example, the PARP inhibitors and so on. So this is a minimal chemoprevention protocol that was provided in the last writing of the protocol. An alternative prevention protocol is offered by reduction risk surgery. For breast, a bilateral mastectomy or contralateral mastectomy is provided with reconstruction. Also, reconstruction is totally free of charge. All this program is totally free of charge from women to reach each woman without any selection bias, Bayes-Dot census, and so on. Women till 14 years old receive self-injectomy, and women from the age of 50 also ovarectomy. The precondition of this surgical protocol is a genetic counseling, profile 3, with or without BRCA mutation, and a multidisciplinary consultancy with the genetist, oncologist, radiology, and psychological counseling before 5-6 meetings before and after surgical intervention, and obviously informed consent obtained by the patient. So the patient can accept to enter this protocol and to choose the preferred protocol in case of high risk. Surgical protocols or follow all protocols come with chemoprevention. These are further support to high-risk women, psychological, obviously, but also regarding lifestyle, practical diet, and physical activity to follow, obviously. And this is a first outcome result after 4 years of the program. This is a 2006 study published in which we had an overlook of women examined in the hub centers, the genetic centers, after 4 years for the program start. We are starting now. You see that we have at times in 2006 we had in charge 544 the women with BRCA mutation, with germinal mutation, and over 5,000 women at high probability to have a cancer within the age of 70. So this intervention is a heavy intervention of this type of risk. At present time, we have verified the profile risk, linking this data with the one of the cancer register, verified that the profile of risk attributed for the program is coherent with anamnestic cancer history. And we are now starting with several deep findings after 10 years regarding the risk profile and the quality of follow-up followed and the appropriateness of follow-up followed. And we hope to publish the first result next year. Well, that's all for the moment. I thank you for the attention. Excuse me for the length of the presentation. The condition of the presentation was quite problematic for me because I didn't see you, and I have some problem with the slides. But I'm now at your disposal for a question if needed, and try to answer it. Thank you very much.
Thank you so much for this very big work and presentation, because I think it's the first time I see this kind of comprehensive work in screening, which cover all questions during the screening program. Nowadays in Uzbekistan we started to implement, but I think your one is very perfect. So I should ask you, is there any questions to our professor? Если есть у кого-то вопросы, можете задавать. Is there any questions? No questions. Dear professor, can you share the information of your slides? I mean, can you send it to me
Yes,
on
obviously.
email, because it was
Obviously.
very useful. I think it's very useful for the managers in the field of screening.
Yes, I will send you all the PowerPoint presentation, so we'll share. You will share it with the person present now, then with everyone, if you want.
I have the question, which is the screening programs difference from the region to region? I mean, is it only in your region or in all over Italy?
The program is compulsory in all Italy, because the Italian Ministry of Health says that each region must guarantee its women and its population, because the colorectal screening is also for males. But until now, although our screening started over 25 ago, but till now, several regions have an insufficient coverage of screening. So we have, as a nation, a great problem of coverage of breast, of cervical, and more for colorectal cancer that have showed us excellent results. In our region, we had a particular attention for this type of prevention, because this type of prevention is greatly cost effective. This allow us to avoid women with intensive care, with guarantee them better quality of life, but also to spare several resources for other problems, and especially for cancer with so high incidence as breast and colorectal cancer. For cervical cancer, we have in practice now, for us, cervical cancer is a rare cancer. In our region, we see less than 100 cases per year. It's extremely important that the coverage is large and all the population is covered, because with the coverage of 50, 40, or 30%, the screening is totally inefficient. So it costs and gives no benefits.
And there is one question in the chat. I think that doctor connected some later. That's why he asked, what is the percentage of the detection of breast cancer during the screening?
The detection rate, yes.
Yes.
I see you the detection rate. You see the slide?
Yes.
Yes, this is the detection rate for carcinomas in different class of age. In practice, we found 4,000 cases in 49 years, 12,000 cases and so on. And these indexes are very important, because if they are low, this means that screening don't work. If it's too high, that there is an overdiagnosis that have to be corrected, because we don't expect too low and too high percentage of diagnosis of screening women. And this is in detail in terms of the percentage, in terms of rate, the level of diagnosis in screened women by different ages.
And do you have any data about how many women detect the breast cancer by themselves, by self-examination maybe? So do you have any data? Because mostly in post-Soviet Union countries, we talk about how many woman detected by the mammogram, how much detected by breast self-examination maybe. So is there any data? Oh.
We don't have a precise data on this topic because it's difficult to have information of self-detection. But I see on the slide, we have built a program for quick taking charge of women who experience a breast nodule of a breast sensation of a breast disease. Because under this condition, new nodule discovery, increase of size in already presented nodules, such as often in young women, nodule are fibromatomas, so not. But skin and nipple retraction, this is a sign of a late stage cancer. But blood discharge, persistent nipple erosion, palpably a single lymphadenopathy. In all these conditions, we are able to take in charge of women within 72 hours. That means that a nodule discovered on Friday afternoon is taken in charge on Monday morning. So the self diagnosis is rapidly taken charge by our system, and obviously the diagnosis has to be confirmed by mammograms.
I see. Is there any questions? Oh, I think no questions. If you share the presentation, it would be very useful for our people, I think. I hope we can hear you next time again. Thank you so much for your presentation.
Yes, I will send you the presentation by mail. And if it could be too much heavy is to be said by mail, you can tell me, and we'll find another way. Excuse me for my low quality English, but
no, it's very good one.
I try the best for me.
Yeah, very big work. I'm impressed of your big work here.
Thank you.
Thank you so much. See you next time. Welcome to Uzbekistan.
See you next time. Thanks to all. Goodbye.
Bye bye.